Welcome to the second week of summer semester. So today we are going to discuss the continuation of the previous lesson, some overview of chemotherapeutic agents that can be used in the management of different neoplastic conditions. So if you remember, we have covered about other class of drugs. So today we are going to see the remaining one, the newer targeted therapies, then the hormonal agents, and the platinum analogs. Okay, so from platinum analogs, we do have cisplatin, carboplatin, oxaliplatin. By the way, all of them are available locally. They are mostly used in the management of solid malignancies. So let me leave the chemical structure of the drug for the medicinal chemistry. But this class of drugs, they do have platinum complex in the chemical structure. That is why they are called platinum analogs. So in terms of mechanism of action, they form, they actually causes inter and intrastrand DNA cross-link like alkylating agent. By doing this, it can actually inhibit DNA synthesis in the cancer cell. So this is the principal mode of action of platinum analogs. So in terms of side effect profile, all platinum analogs has a potential to cause hypersensitivity reaction, including anaphylaxis. So that is like the class-specific drugs, the class-specific side effects of platinum analogs. So platinum analogs are the class, they can cause hypersensitivity reaction. However, there is actually drug-specific side effects even among the platinum analogs. Like cisplatin, it has unique side effects, carboplatin, and even oxaliplatin. Okay, so in terms of side effect profile, uh, uh, from platinum analogs, cisplatin is the most serious nephrotoxic drugs. That is why, without actually having the renal function test profile of the patient, it is not allowed to initiate platinum analogs because platinum can actually causes even tubular necrosis, yeah, and also even causes electrolyte wasting by interfering different parts of the renal tubule, mainly in the ascending loop of renal and the distal renal tubule. So it is very serious in terms of nephrotoxicity, and it is ototoxic, and it can also cause peripheral neuropathy, emesis, and bone marrow suppression, and ultimately causes anemia. But the most serious one from cisplatin is usually serious nephrotoxicity, and it is highly emetogenic in nature. So the probability of causing nausea and vomiting, even low dose, like as low as in the chemoradiation with cisplatin, normally cisplatin is useful as a radiosensitizer in the management of cervical cancer. As low as 40 milligram per meter square can actually even cause emetogenicity in the patients. So it is very notorious. Then the other class of drug we are going to see is carboplatin. Remember, the potential to cause renal damage, peripheral neuropathy, ototoxicity, and nausea and vomiting is usually less severe as compared to cisplatin. By the way, in case if a patient is not eligible to take cisplatin because of renal profile, usually carboplatin is an alternative. This the alternative drug due to renal toxicity because the possibility of causing renal damage is comparatively minimal. But what is the dose limiting toxicity of carboplatin is myelosuppression. So in terms of causing bone marrow suppression and causing is actually is very high. Carboplatin causes myelosuppression. Cisplatin is notorious to cause nephrotoxicity. Then the other drug we're going to see is oxaliplatin. By the way, oxaliplatin is the most commonly used drug in combination treatment of colorectal cancer. Carboplatin mainly in cervical cancer and even lung CA, but oxaliplatin is most effective in colorectal cancer patients. So in terms of ADR profile, is no nephrotoxic and ototoxic. But most of the patients, uh, like those patients who have taken platinum analogs, usually like complain ringing in the ear, what we call like tinnitus, like the syncona or synconium, like side effect, such as ringing in the ear is very common with cisplatin administration because of some damage on the ear. Yeah, so oxaliplatin is very likely to cause, and it has moderate emetogenicity potential. But what is unique with oxaliplatin is the possibility to produce peripheral neuropathy. It is actually the most common or the dose-limiting toxicity is neurotoxicity. It can cause mainly peripheral neuropathies. So, most importantly, when a patient is taking oxaliplatin, it is usually advisable to avoid cold exposure because most of the time, the, the peripheral neuropathy, which is caused by oxaliplatin, is usually induced by cold exposure. If there is a cold, now it will exacerbate. Because of that, we have to advise our patient when they are on oxaliplatin combination regimen, we need to tell them to avoid any cold beverages like soda and also even milk in case then any cold products, they have to have like adequate wear during the cold season. Otherwise, the peripheral neuropathy is very high. So that is the unique toxicity of oxaliplatin. That is why if a patient develops peripheral neuropathy, mostly those neuropathic pain drugs for neuropathic pains are usually useful, like the like the amitriptyline, duloxetine, and even the other classes, the gabapentin, they are also important in management of oxaliplatin-induced peripheral neuropathy. Well, this is all what we have for platinum analogs. So don't forget cisplatin nephrotoxicity, carboplatin myelosuppression, oxaliplatin peripheral neuropathy. Those are the drug-specific side effects of platinum analogs. Then now, toward the end, let us see about miscellaneous agents. Bleomycin. So bleomycin is also available locally. So this is how the product look like the packaging material. Remember, bleomycin works at the G2 phase of the cell cycle and ultimately causes oxidative damage to DNA producing single or double strand break. That is the mechanism of action of bleomycin. Bleomycin is commonly used in the management of non-Hodgkin's lymphoma. There is a combination regimen known as ABVD in the management of Hodgkin's lymphoma. So A is for uh, uh, doxorubicin, B is for bleomycin, V is actually for we shall see this one vinblastine dacarbazine. So bleomycin is one of the combination regimens and in Hodgkin's lymphoma. So we shall see it. So it is just one of the combination medication. Then it can cause hypersensitivity reaction, alopecia, nausea, and vomiting. But what is dose limiting with bleomycin use is pulmonary toxicity. If there is a cumulative dose, remember what we have covered, what we have said in anthracycline. So when there is a cumulative toxicity, the possibility of cardiac toxicity is very high with anthracycline. Similarly, if some patients normally take like beyond the desired cumulative dose of bleomycin, the possibility of toxicity is very high, mainly pulmonary toxicity. So most of the time, if a patient is taking a BVD-based regimen, you need to find out whether they have like pneumonitis or pneumonia-like symptom, like break of dyspnea and infiltratus. Those are some of the chemical toxicities on the lung which is caused by bleomycin. So is very common. Is very common. So at the pharmacies, we need to monitor the possibility of having these ADRs in those patient population. Okay, then hydroxyurea. What do you remember about hydroxyurea? Anyone who is willing to give us where do you recall hydroxyurea, what we have discussed in this semester but last year? Anyone? What other indication do you know for hydroxyurea apart from management of cancer condition? Anita?
Um, so I can try. It's used in sickle cell disease.
Okay, exactly. It is useful in sickle cell disease. So, what is the role of hydroxyurea in the management of sickle cell disease?
I can't remember very well, but I think it makes the red blood cells like a stain shape, like they don't have the sickle shape, so they become more rounder and more
Mhm.
flexible.
Okay, good, real. At least you are in the right track. Huh? The one role of hydroxyurea in management of sickle cell disease is it normally enhances the production of fetal hemoglobin. Huh? By promoting the production of hemoglobin, it reduces like the tendency of sickling of RBCs. That is why hydroxyurea is useful in management of severe case of sickle cell disease. Similarly, hydroxyurea is also useful in management of cancer, mainly uh, chronic myeloid leukemia. By the way, is not really like a front line in the management, but when there's a lot of lymphocytes, cancerous lymphocytes is important for reduction. Otherwise, for chronic treatment, we are going to use other medication, and we shall discuss when we're there. But that is the most primary use of hydroxyurea in the management of chronic myeloid leukemia. So mechanistically, it inhibits ribonucleotide reductase enzyme, which is important for the conversion of the ribonucleotide to deoxyribonucleotide. So this conversion is really very important for DNA synthesis and repair. So in general, when you give hydroxyurea for a patient, it can actually reduce DNA synthesis in the cancerous cell. Okay, then side effect profile, it can cause myelosuppression, nausea, vomiting is very common. Then the other miscellaneous agent, we also have L-asparaginase locally, but it is not commonly used because of hypersensitivity reaction is very common. By the way, L-asparaginase is an enzyme which is produced by E. coli, so it was normally originated or produced from E. coli, which is a bacteria. Yes. Then this asparaginase enzyme is it hydrolyzes the reaction of asparagine to aspartic acid and ammonia. So remember, by promoting this conversion, by promoting asparagine to aspartic acid, it normally reduces like the most important component for protein synthesis in the lymphoid cell. So asparagine. So it deprives or depletes the amount of asparagine, which is important for protein synthesis of lymphoid cell. In such a way, it can actually treat acute lymphoblastic leukemias and acute myeloid leukemias, but it's very common in ALL management. Because of hypersensitivity reaction, as I said, the use is not really very common. But this is how it works, and you can actually even see how asparagine look like. Then I hope you remember about thalidomide, lenalidomide, and pomalidomide when you are discussing about maybe antimicrobial agents, most likely you have covered it. So what do you know about thalidomide? City, okay.
It can cause birth defects.
Yes, so it is actually back 1915s. It has been used in management of now morning sickness in pregnancy, as well as sedative hypnotics agents. So, but mostly when they used for morning sickness in the year 1915s, normally they realized the mothers normally delivered like a child who is having no limbs, upper or lower limbs. So this is the well-known teratogenic agents, which can actually is known as category X and causes well-known teratogenicity if there is exposure during pregnancy. However, by the way, nowadays, thalidomide is also useful in the management of leukemia, sorry, cancer condition, mainly multiple myeloma. By the way, do you know we do have thalidomide locally? We do have thalidomide and lenalidomide, even pomalidomide, but two of them are most common. So those are the original drug, the pro-drug, so the original drug. Then the other drug is we call them thalidomide analogs. They are available locally, by the way. But remember, when you use maybe in someone who is actually having in the reproductive age group, adequate contraceptive is very important. A minimum of like 4 weeks even after discontinuation and 4 weeks before treatment, they're supposed to ensure adequate form of contraceptive because they're well-known teratogenic medication. Then, in terms of mechanism of action, it is a pro-radical oxidative damage to the DNA, and it also inhibits tumor necrosis factor, alpha production, which is important for proliferation of the cancer cell. Then it also even alter cancer adhesion and also even alter cytokine in such a way it can actually affect the growth of cancer cell. So we call them by the immunomodulatory agents because mostly they're working to modulate the immune factor, like tumor necrosis factor, adhesion of the cancer cell, as well as cytokine level. In such a way, it can be used in management of cancer. So the most well-known use of thalidomide is currently, according to the current evidence, it is very popular in management of multiple myeloma. So multiple myeloma, we shall discuss later, is a type of cancer that affects the plasma cell, the plasma cell. So there is excessive plasma cell antibodies that can actually vary cancers and cause a lot of destruction. Okay, then very important point to note, if you don't mind, please listen carefully. And what is very known with thalidomide, apart from teratogenicity, the possibility of deep vein thrombosis is very high. By the way, it has some role in actually causing it can actually even cause some uh, uh, the risk of thrombosis. It's normally interfere in coagulopathy. Because of that, like all thalidomide as well as even its analogs are known to cause deep vein thrombosis. That is very important information to note. Then, because of this reason, when a patient is taking thalidomide, there must be a prophylaxis agent, mostly in low risk individual. That means like those patients who are not very old, those patients who are actually mobile and very active, those patients who does not have any risk factor of coagulopathy, they are supposed to take low dose of aspirin throughout the treatment of thalidomide. Otherwise, the possibility of thromboembolism is actually very high. That is why, like one of the pharmacies, when they say a protocol of thalidomide in the regimen, they have to ensure there must be aspirin In fact, aspirin low dose is the most well studied and the most effective prevention modality of DVT in thalidomide treated individuals. So this one is known. So we have to ensure the patient is also along with 75 milligram dose of aspirin. So the role of aspirin here is just to prevent the possibility of DVT. But in high-risk individual, we can also use low molecular weight heparin, but this one is the one which is very common even in our setting. Whether they take thalidomide or its analog, we have to ensure there must be like aspirin throughout the duration of the cycles of thalidomide. That is very important information to note. Otherwise, in terms of side effect profile, the lead drug thalidomide can cause it is actually sedative hypnotic, so dizziness is very common, constipation, peripheral neuropathy. But lenalidomide, in terms of ADR profile, they're actually fewer, but it can cause neutropenia, thrombocytopenia. But DVT, like the clot formation, is common for both the lead drug and it is analogs. So those are very important information to note. Then, toward the end, let us see about monoclonal antibodies. So those are very target-specific class of newer classes of anti-cancer medication. We do have very few, but despite we do have most of them are very expensive and it's very hard for majority of our patients to afford the treatment anyways with monoclonal antibodies. So those monoclonal antibodies, they're actually antibodies and they target with a specific antigen. So by binding with antigen antibody cell complex, it can actually internalize the cancer cell and cause death of the cancer cell. So the way they design, when they bind this with a specific antigen molecule in the body system, they form a complex. So this complex promotes what it promotes normally cellular toxicity or cell death. That is why those class of drugs are target specific. I think this one is available. I'm not very sure about this one, but this one I have seen and mostly used in cervical cancer management. Then, like when you look at almituzumab, remember monoclonal antibodies, they do have a suffix mab. Yeah, that is unique for monoclonal antibodies. So if we see almituzumab, it is an antibody that targets the CD50 receptor, which is found on the B and the T lymphocytes. So remember, when it binds with this cell surface receptor, then it actually normally causes destruction of the cancerous lymphocyte cells. So that is how it works. So it is very common in management of chronic lymphocytic leukemias. By the way, those abbreviations are very common. Most of the time, especially for leukemias, they don't write really the full name. So you'll get ALL, you'll see a diagnosis of AML, you'll see a diagnosis of CLL, you'll see a diagnosis of CML. Those are all types of leukemias we are having in our setting. So, and mostly they put in the abbreviated form, so you have to know what the CLL stands for in the context of oncology, and what does ALL stands for in the context of oncology. So it is your responsibility to familiarize yourself. Then, in terms of side effects, by the way, in general, when someone is taking monoclonal antibodies, the possibility of hypersensitivity reaction is very, very high. So you have to watch out about this. So possible hypersensitivity reaction is usually expected. But apart from that, depending on the type of monoclonal antibodies, we're expecting different types of side effects. For example, for this one, immunosuppression can actually expected. Because of that, prophylaxis, cotrimoxazole, and antiviral agents are usually given to prevent opportunistic infection. Okay, then the bevacizumab, this one is one of the monoclonal antibodies that binds with the vascular endothelial growth factor. Remember, by binding the vascular endothelial growth factor, it actually prevents the new blood formation, angiogenesis in the cancer cell. Remember, one of the molecular mechanism of cancers, they normally promote the expression of the vascular endothelium growth factor, and they promote the production of their own blood vessels. We call them angiogenesis. So the main mechanism of bevacizumab is by inhibiting this, it actually prevents angiogenesis in the cancer cell so that the cancer will not supply blood and essential nutrients for replication. Okay, so that is the real mechanism. Then, when a patient is taking bevacizumab, it can actually causes hypertension, impaired wound healing, thrombotic event, sometimes even protein in the urine, bleeding, and perforation. Remember, vascular endothelium growth factor is vasodilator in nature. So the moment you are blocking this, there is a possibility of increase in the vascular tone. That is why hypertension is commonly associated with the use of bevacizumab because it inhibits vasodilation due to this endogenous growth factor. Then, apart from that, there is also this vascular endothelium growth factor is involved even in like in wound healing by promoting blood flow to the site of injury. So when someone is taking bevacizumab, there is a possibility of impaired wound healing. Then, apart from that, bevacizumab is also involved in repairing of damaged endothelial tissues. So, if vascular endothelium growth factor is also involved in repairing of damaged endothelial tissues. So, in case this drug is inhibiting vascular endothelium growth factor, what will happen? There is a possibility of what? There is a possibility of damage which is promoting platelet aggregation. That is why thromboembolic events can also be happening. Then, when you look at in terms of proteinuria, remember the vascular endothelium growth factor is very important to maintain the integrity of the meshwork of the glomerulus of the kidney. So, if bevacizumab is not, sorry, if bevacizumab is inhibiting this, now the integrity of the meshwork of the glomerulus will be affected and it promotes protein leakage in the renal tubule. Then, apart from that, remember bevacizumab can cause thromboembolic events, sometimes even bleeding, because bevacizumab, vascular endothelium growth factor, normally affects platelet aggregation. So if you inhibit this, now it actually inhibits the possibility of platelet aggregation, so there is high risk of bleeding. So you can actually even explain, you can actually say the different, the mechanism of different side effects as a result of bevacizumab, but it is mainly due to this growth factor, which is having a very diverse function in the body system. So, as a pharmacist, in case if the patient is taking bevacizumab, we have to monitor the possibility of these adverse effects, ranging from hypertension to bleeding is expected. Then the other class of monoclonal antibodies we are going to see is rituximab. By the way, rituximab is a monoclonal antibody which is specifically targeting CD20 receptor on the surface of B lymphocyte. Remember this CD20 receptor, we shall see when you are discussing about lymphomas. Expression is very common in the in lymphomas, specifically in non-Hodgkin lymphoma. So, what will happen when you give rituximab? If rituximab binds with CD20 receptor, then it actually causes antibody-dependent cellular cytotoxicity. So it is only specifically targeting cancer cell that can actually express CD20 positive receptor. But they are molecular tests. We call them staining techniques, but we shall see it that can specifically identify what type of CD receptors are expressed in the in the surface of the cancer cells. So that is why when a patient is having a B-cell lymphoma, which is a type of non-Hodgkin's lymphoma, but express CD4 positive, now if we give rituximab, the possibility of favorable outcome will be very good. And this rituximab is one of the combination treatment regimen in non-Hodgkin's lymphoma. So we shall see when we are discussing about lymphomas, but it's very important even to capture at the early stage. We call them RCHOP. RCHOP is the most common protocol in the management of non-Hodgkin's lymphoma. So it is very common protocol. R stands for rituximab, C stands for cyclophosphamide, H, I forgot, O is vincristine, P prednisolone, and H is for doxorubicin. Yeah, doxorubicin hydrochloride. So that is why they brought H. Cyclophosphamide, oncobin is vincristine, P is prednisolone. So this is the most commonly used treatment protocol in management of lymphoma. So you have to know. So remember, when a cancer cell is positive for CD20, we normally include rituximab. If there is no CD420 expression in the non-Hodgkin's lymphoma, we can actually use only the CHOP regimen. So we shall see it in ways. Then, what is very common with rituximab as an adverse effect is infusion-related reaction is very common, which ranges from hypotension, fever, rash, headache, mild nausea, and vomiting. Because of this reason, the guideline recommends when a patient is taking rituximab-based regimen, you have to ensure to include antihistamine as the pre-medication as well as acetaminophen to reduce or to minimize first dose infusion reaction. That is very important. So acetaminophen prevents the fever as a result of the infusion-related reaction. Phenhydramine normally prevented the hypotension, nausea, and vomiting and other skin reaction. So that is how we are preventing ADRS due to rituximab. Then the other monoclonal antibodies we are going to see is trastuzumab. So is there anyone who heard about trastuzumab? Maybe in medicinal chemistry? Anyone? Patel? Patel, have you heard about this? Anyone? Any other individuals? What are you discussing currently, Stephanie? Tiffany, please.
I only know that it's used in the management of some types of breast cancer.
Okay. Have you ever seen trastuzumab anywhere?
No.
Maybe. By the way, it is widely, I cannot say it is widely available, but it is available locally. It is supposed to be available, by the way, as long as we do have breast cancer. The generic name, the brand name is known as Herceptin. Can you see normally the bottle? Herceptin is the most common brand name for trastuzumab. And of course, most of the doctors nowadays, they prefer writing the brand name. So they usually write Herceptin. Okay, and then any other person who came across trastuzumab? Okay, good. By this week or next week, we shall start discussing about breast cancer. So we shall see it in detail. When are we going to use trastuzumab? So it is one of the monoclonal antibodies which is specifically targeting against human epidermal growth receptor. 2, we call them HR2 positive breast cancer. So this one is specifically targeting HR2 expression in breast cancer. By the way, We shall see it in breast cancer, but to give you some information, before you start treatment of any hormonal receptor or any endocrine treatment for a patient for breast cancer, you have to assess the hormone receptor status. The hormone receptor status means it is actually referring to whether the breast cancer is caused by the hormone. So, for example, if the patient is positive for estrogen receptor, that means estrogen is the most likely hormone that causes that breast cancer for that patient. If a patient is actually PR positive, progesterone receptor positive means is mostly the cancer is caused by the progesterone, and we do have drugs that are specific targeting the AR or PR receptor. And also, we do have a cancer, a breast cancer that is caused by HR2 overexpression. We call them HR2 positive. So most of the time, they usually take tissue sample from the site of the tumor to assess the hormone receptor status. So in general, overexpression, or according to epidemiological studies, overexpression of 15 to 20% of all breast cancers are usually accounted for HR2 overexpression. There was one student, she was currently doing her project on to see how is outcome of treatment on HR2 positive breast cancer patients. She managed to get around 50 something patients. There are very few by the even in number. She took like the 5 years data. From 5 years data of breast cancer patients, she managed to get like around 50 patients with HR2 positive, and she was actually in the final write-up. So in terms of, by the way, outcome, why we decided to study this patient population, according to various epidemiological studies in other countries, it shows HR2 positives are very aggressive. HR2 positive breast cancer is very aggressive, and the possibility of survival is comparatively lower. Because of that, that is why we normally decided. But in our setting, we don't have any data. How is outcome of HR2 positive breast cancer, despite there is a previous report of poor prognosis in the cancer population. That is why we decided to conduct a study along with that student. Anyway, so if you encounter a patient with having HR2 positive, yeah, the possibility, despite whatever maximum treatment you are using, the prognosis is usually very poor. That is why you need to give like proper even counseling to the patient. You don't say, but at least for the close relative, you need to tell them about the possibility of prognosis is actually very poor. So let them decide what kind of resource they are going to expend. So it is very poor. But for HR and AR positive, for PR and AR positive breast cancer, if they are actually positive for this receptor, they are very lucky. So the possibility of prognosis is actually very high. By the way, in our setting, like not only even in our setting, globally, the AR and hormone receptor positive breast cancer accounts the majority of the cancer of the breast in our setting. Either they are AR positive or PR. If they are all triple negative, that means HR, AR, and PR, the prognosis is still very poor. Okay, then having said this much, make sure you have to know before you start trastuzumab, you have to know the hormone receptor status. By the way, before you use tamoxifen, you have to know the patient is actually having AR or PR positive. If you don't, if they are negative, there is no essence of giving endocrine therapies for those patient population. We shall discuss maybe next week about this treatment approaches. So that is why if a facility is having cancer center, it is very essential to have like a lab parameter that can assess the hormone receptor status. Because even epidemiologically, breast cancer is the most prevalent type of cancer, even locally. If we don't have, the oncologist will be actually encounter difficulties whether to initiate endocrine therapies or even trastuzumab if available. So it is very important. If you don't know the hormone receptor status, there is no rational or there is no scientific reason whether we are going to use hormone receptor endocrine therapies or monoclonal antibodies such as trastuzumab. So this was the major challenge, even what we have seen in our country, because I don't think so even they normally do even hormone receptor status in the country, but at least in Kenya they do in some facilities. Okay, so because of that, if the patient does not have HRO2 positive, they don't respond to trastuzumab. So that is why without knowing this, it is very hard to initiate trastuzumab. Okay, mostly it can be used as a single agent or a combination with anthracycline or taxane-based combination therapy. Another important information to note with trastuzumab, it can actually even causes some cardiotoxicities, but the damage is not very severe like that of anthracycline. It's not very severe like that of anthracycline, but cardiac monitoring is usually advisable because they are also cardiotoxic monoclonal antibodies. So severe congestive heart failure may occur if we give them concurrently with anthracycline administration. By the way, in general, even the protocol of cancer treatment normally recommends not to combine trastuzumab along with anthracycline class of drugs in case if the patient if the patient is HRO2 positive and we are going to initiate chemotherapy along with trastuzumab, it is usually not advisable. In the first place, if we combine, we increase the risk. But what are we supposed to do now? Give anthracycline first. That means the chemotherapy, by the way, do you know the chemotherapy? They do have very quick onset of action. Chemotherapy is actually having very quick onset of action as compared to monoclonal antibodies or endocrine therapies. Because of that, if your target is to cure, give chemotherapy first. Then after you complete the chemotherapy cycle, that is when we are going to consider initiation of the endocrine therapies and monoclonal antibodies such as trastuzumab in breast cancer. If you combine them, it increases the risk. So don't combine anthracycline with trastuzumab. So if you're working in the oncology pharmacy, the moment you see a prescription, so you need to give proper instruction to the respective, maybe the respective doctors in charge. So don't combine because of this and this reason. Okay, but despite it causes cardiotoxicity, the most common one is first dose infusion rate reaction is very, very common. By the way, in case if the patient develops like hypersensitivity due to anti-cancer medication, mostly they use the steroids. Yeah, those are the most common treatment modalities for hypersensitivity reaction. So are we together? So how many of you are listening? Maybe can you raise your hand if you are listening? All of you just raise your hand using the. So that means few people are actually missing. Okay, sawa. So at least more than 95% normally are attending. Okay, thank you. 42, 41 out of 47. Okay, then the other class of drugs we are going to discuss. But in cancer, if you know the drug is very well, you are good to go. Because like you are not even supposed to cram the whole protocol because the protocol is normally they do have their own specific protocol for each type of cancer. When you go to a certain facility, they will give you Like this is how we are managing prostate cancer. This is how we are managing breast cancer and etc. So because but you have to know the drugs very well. That is very important, by the way. Now let's see about tyrosine kinase inhibitor. By the way, this class of drugs, I don't think so even. I think they just discovered recently, not more than 20 years. If you are interested, you can go and check when was the first tyrosine kinase enzyme inhibitor discovered. It is actually one of the newer anti-cancer drugs available in the market. They are inhibiting tyrosine kinase enzyme. And from this, imatinib is the oldest. Imatinib is the oldest. So if you see a suffix nib, uh, they are under the classes of tyrosine kinase inhibitor, imatinib, sunitinib, but this one is widely available, but it is very expensive it is very expensive molecular. Okay, they are known as a small molecule inhibitor, and so the main role of tyrosine kinase enzyme inhibitors are usually in the management of uh, uh, chronic myeloid leukemia or acute lymphoblastic leukemia. So remember, like in some type of leukemias, there is a possibility of chromosomal translocation. For example, in this case, what will happen in case of CML, there is a chromosomal translocation between chromosome 9 to chromosome 22. That means some segments of chromosome 9 translocate to 22 and causes the production of Philadelphia chromosome. So this Philadelphia chromosome, normally what it causes excessive activity of tyrosine kinase enzyme. So when there is excessive expression of tyrosine kinase enzyme, it actually promotes cellular growth and proliferation. Because of that reason, and this one is very common, like this chromosomal translocation and causing overactivity of this enzyme is very common in the pathogenesis of chronic myeloid leukemias. So if you do have a patient with chronic myeloid leukemias, these tyrosine kinase enzyme inhibitors are the front line, and mostly imatinib, which is widely available, and it is usually available in the oral formulation, and the common strength is 400 milligram. We shall discuss in detail when we are discussing about CML, but this is the gold standard management. It is the most effective treatment available in the market for management of chronic myeloid leukemias. As a result of chromosomal translocation, there is Philadelphia chromosome. This Philadelphia chromosome is normally causes overactivity of tyrosine kinase enzyme, promotes proliferation, and ultimately causes chronic myeloid leukemia. So that is the front line. Then imatinib is a gold standard management, is the oldest. I think imatinib is also available, even this one is available locally. Yeah? So maybe in the future, when you practice in that area or when you do the internship, most likely you can actually experience those anti-cancer medication. So this is all about some of the anti-cancer drugs in brief. Remember, for details, I just leave for Amias to discuss in detail. Then, now, let's see about hormonal therapies. So I hope you have mentioned somewhere about the role of hormonal therapies in management of cancer. So specifically in the breast cancer and prostate cancer, this class of drugs have really having good strategies, and the possibility of outcome is very good. And we normally give hormonal therapies when a patient is having like hormone receptor positive breast cancer, but it is very gold standard in management of prostate cancer. So hormonal therapies, they either block or decrease the production of endogenous hormone, which is most likely causing or most likely increasing the risk of what? Most likely causing the risk of cancer by causing the growth and proliferation. So like in case of breast cancer or breast CA, the most common growth signal is estrogen. Then in case of prostate cancer, prostate CA, the most common growth factor is normally testosterone androgen, but the most common androgen that causes this one is testosterone. So that is why some hormonal therapies are targeting either to block or to reduce the production of the endogenous hormone. So this is the whole mechanism of action. Then the first hormonal therapies we are going to see for today is anti-androgen. So anti-androgen, the term itself is self-explanatory, sorry. They block the action of androgen. So flutamide, you can actually even see they do have amide as a suffix, bicalutamide, flutamide, nilutamide. Those are the most common androgen. So the anti-androgen block androgen receptor to inhibit the action of testosterone and dihydrotestosterone in the prostate cancer cells. So they are the most commonly used drugs in managing prostate cancer. Remember, in prostate cancer, the most common growth signal is either testosterone or preferably the most active form of testosterone is dihydrotestosterone. So that is why anti-androgens are the most common hormonal therapies. Then, because of anti-androgenic effect, they can cause hot flash, gynecomastia, and decreased sexual desire is very common with this class of drugs. Okay, then the other class of drugs is the luteinizing hormone releasing hormone agonists. They are still useful in management of prostate cancer. Gostrolin and leprolides are very common. Remember what we have discussed, this class of drugs. Initially, they promote the growth of the hormone, but later on, when there is a continuous stimulation, they do have like we call them like down regulation. So there is a desensitization of the receptor, ultimately reduces the production of estrogen and progesterone, estrogen and testosterone. But mainly, the main use is not, it can actually be useful to treat breast cancer and prostate cancer, but the most common use is mostly in managing prostate cancer. Okay, major side effects are testicular hypertrophy, decreased sexual desire, and gynecomastia are very common because of the effect on the testosterone level. So they can cause increased risk of gynecomastia. So those are the class of drugs we're having. Then, have you heard about aromatase enzyme inhibitors? Have you heard about aromatase enzyme inhibitors?
Yes.
Yes.
So what do you know? What do you know about aromatase enzyme inhibitors? What is the principal role or mode of action? By the way, I remember we have mentioned this one when we are discussing about endocrine disorders, for sure.
They inhibit the aromatase enzyme.
So what is the role of aromatase enzyme?
I think, was it conversion of testosterone to estrogen? Or something like that.
Yeah, you are right. It is important in the conversion of androgen to estrogen. So aromatase enzyme is very important in the conversion. So by reducing the conversion to estrogen, they're actually important the management of reducing the growth signal, the most common growth signal in breast cancer, which is estrogen. So that is the main role. So they reduce the conversion aromatic androgen to estrogen. So ultimately, they reduces the estrogen level. So what endocrine disorder can be treated by aromatase enzyme inhibitors? Which endocrine disorders we have mentioned last year when we were discussing about endocrine disorder? Anyone who recall? You don't even remember about some of the endocrine disorders were mentioned, which is very common in female. I'm waiting the response. Huh? Okay, fine. So you go and find out. Huh?
So is it menopause?
No, it is not menopause. There's one endocrine disorder were mentioned when you are discussing about endocrine disorder. It is an inflammatory condition caused by, you can go and check, you will get the answer. Okay, fine. Then, as I mentioned before, this one, aromatase enzyme inhibitor, anastrozole and letrozole, they are widely available. What I'm not very sure is exemestane, which is a steroidal aromatase enzyme inhibitor. That means it has a steroidal nucleus. So by the anastrozole and letrozole, they are the most widely available aromatase enzyme inhibitor that can be used in the management of breast cancer by reducing the level of estrogen. So this is the most commonly used drug in management of adjuvant treatment of postmenopausal women with hormone receptor positive breast cancer. So when you say hormone receptor positive, it could be either ER or progesterone receptor. So if they are positive for both, we can actually consider an adjuvant treatment. But remember, these aromatase enzyme inhibitors are exclusively used for postmenopausal women breast cancer. So what if we use in the premenopausal woman?
It will affect ovulation and the ability to get pregnant because it affects the estrogen levels that they need for normal reproductive functioning.
So that means because it affected the reproductive functioning, we have to use it only for postmenopausal women. That is what you said, Tiffany, yeah?
Pardon?
That is what you said, that because of the effect on the reproductive functioning, we don't use it in the postmenopausal woman, in the premenopausal woman.
Well, that's what I think.
Okay, any other person? Why we use aromatase enzyme inhibitor in? Okay, let me say, if we use in the premenopausal woman, aromatase enzyme inhibitors are not effective. You know, at this point in terms of cancer treatment, we are not really giving much attention about the possible fertility issues, like especially in this condition. So if the tumor is very aggressive, we treat aggressively, yeah, without compromising the possibility of survival, not really about the issue of reproducibility. Okay, any other?
Sorry, is it because in premenopausal women, they are able to endogenously produce estrogen in the body, while postmenopausal women rely almost solely on the conversion of testosterone to estrogen to produce any form of estrogen in the body because they no longer produce estrogen from the ovaries.
Exactly, that is what I want to say, yeah? Okay, remember after menopause, ovary is no longer functioning. If ovary is not longer functioning, means like there is no estrogen. Then if you use in the premenopausal woman aromatase enzyme inhibitor, the moment you block the conversion and the estrogen level is actually sensor low, now the ovary will produce more of the estrogen and even more of the aromatase enzyme, and it actually inhibits the conversion. Because of that, Because of that, if you give aromatase enzyme inhibitor in the premenopausal woman, you are not treating that patient for the breast cancer. Because of that negative, because of that, what do I call, like, counter effect, it can actually causes overexpression of ovary to produce more aromatase and more estrogen. Ultimately, it counteracts, or it actually reverses the effect of aromatase enzyme inhibitor. That is why if you see a doctor who give normally aromatase enzyme inhibitor in the postmenopausal woman, that means you need to teach him or her. Yeah, that is very important. For premenopausal women, we usually use tamoxifen. Tamoxifen can use in the premenopausal as well as in the postmenopausal woman. So remember, in the postmenopausal woman, the only source of estrogen is only adrenal gland. They will get the estrogen for survival from adrenal gland, but adrenal gland only produces 5% of estrogen in the ovary. That is why in that conversion, that is why this 5% will not prevent the menopausal, postmenopausal symptom like osteoporosis, bone pain, the hot flash, and etc. Okay, good. So this one exclusively used in the postmenopausal woman breast cancer, but it should be hormone receptor positive. So you have to note. Then another point to note with aromatase enzyme inhibitor, exemestane is a reversible inhibitor. By the way, despite it is an irreversible inhibitor of aromatase enzyme inhibitor, according to comparative studies, there is no difference in the outcome of the breast cancer between a non-steroidal aromatase inhibitor with a steroidal aromatase enzyme inhibitor. Despite it is reversible, there was no difference in terms of outcome. So we can pick any depending on availability, but this one is the most widely available. Then, what are the most common side effects as a result of aromatase enzyme inhibitor therapy? Osteoporosis. Don't forget, by the way, if I asked you what is the most common side effect as a result of aromatase enzyme inhibitor, you have to say osteoporosis. But why it causes osteoporosis? Why osteoporosis with aromatase enzyme inhibitor?
Sir, is it because there's reduced estrogen, which normally acts to protect the bones?
Yes, it is just because of estrogen, and estrogen is very important for bone formation, especially it normally promotes osteoblasts in the female. So, like, they do have very few amount of estrogen by the because then the moment you introduce aromatase enzyme inhibitor, the possibility of osteoporosis will be very high. So this is one of the serious side effects as a result of this medication. Then the other hormonal therapy, and the most widely used, by the way, is tamoxifen. So for sure, you have even covered in the endocrine pharmacology. So what do you know about tamoxifen? What do you know about tamoxifen? At least you can say a few words, huh? What do you know about tamoxifen? Let me ask you. Sylvia. Sylvia, are you available?
Yes, I'm here, sir. But
wow. So you have never heard about tamoxifen?
No, not yet. Not yet, sir.
No. You have not covered endocrine pharmacology for sure. Selective estrogen receptor modulator. You have not covered about selective estrogen receptor modulators.
We have.
Yeah, so those are under the classes of selective estrogen receptor modulator. So from selective estrogen receptor modulator, tamoxifen is the most effective, by the way, in managing. I think that is the only drug in managing breast cancer. And because this one is the most effective antagonist of estrogen on the breast tissues as compared to the other tamoxifen, as compared to the other selective estrogen receptor modulator. Why they are called modulator? Because they are antagonists on the breast tissues, but they are agonists in the other tissues. On the bone and in the uterus, in the endometrial tissues, and even the other sites, it has agonist effect. That means it actually has estrogenic effect. But in the breast tissues, it is normally antagonistic effect. That is why tamoxifen is the most widely available hormonal therapies for premenopausal or postmenopausal hormone receptor positive breast cancer patients. So side effect wise, remember it has, because of estrogenic effects on the other tissues, osteoporosis is not affected. So we don't expect osteoporosis because in the bone, tamoxifen has estrogenic effect and it promotes bone. It actually promotes as well like bone formation. Then the major issue is because tamoxifen normally affects has estrogenic-like effect on the liver clotting factor, it actually increases thrombosis. By the way, this is the major aspect we are going to monitor. If a patient is taking tamoxifen, I have to monitor the possibility of thromboembolism because tamoxifen has estrogen-like effect on the clotting factor. It actually increases the concentration of clotting factor and increases risk of thrombosis. Then, apart from that, because of the effect on the endometrial and uterine growth, it can actually cause what? It can cause uterine cancer and endometrial cancer. So what I have said about the gonadotropin-releasing hormone is endometriosis. Endometriosis is the most commonly used. This one is the most commonly used drug in managing endometriosis, which is mostly caused by estrogen. Okay, then those are the most common things by the, and it is available orally, and it is usually given 20 milligrams once daily, and the patient is supposed to take continuously for 10 years. There is one student who was being normally adherent for tamoxifen in like those patients who are taking endocrine therapies. Okay, of course, she's not normally collect the data adequately, but remember this one, tamoxifen is usually given for 10 years. For 10 years. Initially, it was for 5 years, but nowadays, like they said, like if you give for 10 years, you are actually expecting like very improved treatment outcome and improved survival. So because of that, normally nowadays they are taking for 10 years. So that is the recommendation. Then above 10 years, according to the studies, there is no evidence about the benefit of tamoxifen in breast cancer. So we don't give beyond 10 years. But now you can actually even imagine how many patients can afford tamoxifen. It's not very expensive, but how many patients are actually very dedicated to take tamoxifen continuously for 10 years, and it is normally a daily dose. It's just like you have to remember like your breakfast, dinner, and lunch. You have to recall them and take your medicine. Okay, that is very important point to note. Yes. Then one problem with tamoxifen is also there is drug interaction with SSRIs, selective serotonin reuptake inhibitor. So maybe you go and find out what is the interaction between, in case if the patient is taking antidepressant along with tamoxifen, what will be the possible drug interaction? So go and find out, and then you let me know. Okay, by the way, this is all in brief about all anti-cancer medication. Do you have any question? You are welcome. Any question?
Sir,
Yes, please.
I have 2 questions.
Please.
First of all, tamoxifen or the modulators, they're only antagonists on breast tissue and agonists everywhere else.
Yes, there are all selective estrogen receptor modulator. That is what I know. They are antagonists on the breast, but they are agonists on other tissues.
Okay.
Yes.
And the last question, Does testosterone have similar bone protective effects on men as estrogen in women?
Okay, that is a good question. But mostly testosterone is I think it does. But allow me to check, or maybe someone help us to check. But mostly testosterone has some role in bone strength. So I think most likely it has. But uh, it normally promotes bone density. I forgot normally, like, like if you see the strength of the bone between male and female, the male bone is more stronger than the female bone because of the testosterone is actually causing like bone mass, bone strength to become muscular in etc. But I'm not very sure specifically unless I check. Then allow me to check, Tiffany. Yeah, allow me to check, then I will let you know.
Okay, sir.
Yes,
Thank
but
you.
it has a role. It has a role in the bone strength. But let me check about the latest information. Okay, any other question?
I have a question.
Please.
I don't know whether I should save it for breast cancer, but I just wanted to ask. Since tamoxifen is specifically used for breast cancer and how it's working, is it still the drug of choice for men who develop breast cancer?
Yes, by the way, in fact, a few percentage of the male normally have breast cancer, and mostly the major cause of male pattern breast cancer is usually hormone receptor positive. So because of that, tamoxifen is normally the drug of choice. If you encounter a male who is having breast cancer, regardless of even the hormone receptor status, tamoxifen is the drug of choice for endocrine therapies.
Okay, thank you.
Any other? For sure, you might have several questions if you listen carefully. Yeah. Any other? Any other questions? Okay, fine.
Another question.
Please.
Say someone has like multiple cancers. Is there like a rationale to what cancer to give priority to first?
That is a good question. In my practice, despite it was very short, not longer than like a year, from my practice, I've never seen a patient who is having many cancer at a time. Yeah, that one maybe I will ask the oncology practitioner, like working on a KNH. But priority is usually given like someone which is very aggressive. In case if you encounter multiple cancer at once, priority should be the most aggressive one. Like if you see, like if someone is having like leukemias along with solid malignancies, the leukemias are more aggressive than the solid malignancies. So if you see a patient is having maybe stage advanced disease of one cancer, but the other cancer mild stage, you give priority for advanced stage because advanced stage is actually very fatal and it can kill the patient. So I don't know, maybe I need, maybe go and check how frequent is actually having multiple cancer, like many cancer in a single patient. What is very common is normally one type of cancer. Maybe concurrently is very likely, but I'm not very sure about that even. Like cardiac cancer, it is very rare, but we don't know why the heart tissue is actually preserved from having malignancies. It is very likely to get by the heart cancer. It is very rare, very rare. So, but no one knows why the heart is normally protected from having malignancies. Maybe the heart is not undergoing proliferation. Normally, the heart tissues and the neuron tissues, normally after they mature, they put in genote stage, and that is resting phase, and they don't proliferate. I don't know the main reason. But that is what I know I need. But maybe I will give you a home take assignment for Wednesday. Can you go and check how frequent is having multiple cancer in a patient? Are you willing to give us update on Wednesday?
I will try.
Yeah,
I
please
also have,
try.
I also have another question. I
Please,
don't know whether it's in regard to the same.
it's fine.
What happens when, okay, is there rationale for treatment of cancer with other chronic conditions? Say someone has cancer and HIV at the same time, or cancer and failure and all that.
It is very common by the some condition normally promotes even to develop cancer. For example, like in HIV, you know, HIV infection can increase risk of lymphomas. It is very common. There is also HIV associated cancer. Can you remind me normally that type of uh, no. Anyone who can recall about Kaposi sarcoma, yes. It is very common. It's morely associated with HIV associated cancer. So you will encounter several cases with some comorbidities. But if the patient is having comorbidities, like treatment is really very hard. Yeah, otherwise it is very common in some. Then if you see a patient with chronic hepatitis cancer, hepatitis C infection, you are expecting to have hepatocellular carcinoma at some point. Someone with chronically having liver problem, they are having risk of hepatocellular carcinoma. It's very common to have this kind of condition. If I got your question, that is what you asked, Annette, yeah?
Yes.
Okay. Any other questions?
I'm sorry, I had one more question.
Please.
Sorry.
Okay, no problem.
When you were talking about the factors that determine what kind of like anti-cancer drug to, I mean the kind of treatment being given for cancer, we talked about cost. And when you were explaining here, you also said that different hospitals have different like protocols or ways in which they manage like the kinds of cancer that they deal with. So my question is, when you say cost, does it mean that there are people, like in your experience, have you seen people getting like a lower quality anti-cancer drug because it's cheaper and they are going to a hospital which is what they can afford compared to like another hospital which is maybe expensive, but the anti-cancer drug there is better?
Okay, that's a good question, by the way. So when you say cost, remember, like one typical example I can give you is like the CHOP regimen. So if you do have a lymphoma with CD20 positive, CD20 positive, the best treatment is R-CHOP. But in case if the patient is not affording the rituximab component, you can give them CHOP. But the guideline recommends the better treatment outcome will be with R-CHOP as compared to CHOP, but still the patient can respond for CHOP. Yes, then sometimes you are supposed to use combination therapy, but still monotherapy can work. But according to the current evidence, combination therapy is more effective than the monotherapy. But if the patient can afford, maybe you can try with monotherapy. So this kind of issues are very common. Then apart from that, like a patient is having HR2 positive breast cancer, but they cannot afford trastuzumab because trastuzumab is very expensive. Sometimes even may not available. But if the patient cannot afford trastuzumab, what you can do is you just give the normal chemo. But the treatment outcome will be better if you give them the chemo along with trastuzumab, specifically if they are HR positive breast cancer. So this scenario is very common and very challenging. For sure, if you get a chance to go maybe in Janet, you will see this kind of issues severally. Now, a bit in order now. Did I answer your question? I don't know.
Somehow. Yeah, thank you.
Yeah, but it is very common. But otherwise, it does not mean that it is low quality, but the most effective regimen can be deterred because of cost. Yes, if targeted therapies are very effective according to the current evidence, if you don't have targeted therapies, what are you going to use it? You just use it what you have. Yeah. Okay, any other?
So I had a question. Oh, sorry.
Uh-huh.
In relation to Annette's question about having multiple cancers in one person.
Mhm.
In the case of metastasis, so you have, maybe it started as breast cancer and then you had it spreading either to the liver, the kidney, the brain, or another organ. Do you treat the breast cancer first, or treating that breast cancer will also translate to treating the cancer that is spread into another organ?
Yeah, by the way, that is a good question. By the way, if there is metastasis, like the treatment is palliative, we don't cure. So the treatment modalities normally for palliative, like for metastasis type of cancer, is normally palliative approach. Maybe if there is like what do you call, so still the treatment will be targeting the breast cancer, but despite we target the breast cancer, it's just to prevent further spread to other organ. In case initially it might be spread to the lung, but if you just treat very well, so that it will not spread to the other organ. But still, if there is lung involvement, for sure, the probability of spread is actually very high. So, for you still treat the breast cancer, but you normally symptomatically manage the other one. Maybe if the intracranial pressure is elevated, if there is a bone pain, that means you have to consider palliative treatment. So, there is like the treatment modalities we are using is in metastatic setting is still palliative. That means we are going to introduce anti-cancer medication along with other symptomatic management, such as steroids, such as like zoledronic acid in case of bone involvement, maybe in case of inflammation in the brain, we might use even steroids and etc. Yeah, that is how we are managing. Yeah? Mm.
Okay, so thank you.
Any other question, or we move to the next point?
So are there any approved natural ways of treating cancer?
Sorry, any
Are there
approved?
any natural methods of treating cancer?
Natural method.
Yes.
Natural method means like, oh, this one, like if, good question, by the way, maybe not really natural, maybe let's say prevention modalities. Sometimes if someone is having high degree risk of high first degree family history of breast cancer, maybe the other, like the children, they can actually even consider to use tamoxifen as a chemopreventive therapy. Then in case of prostate cancer, maybe like if they do have high degree of family history of cancer, maybe like they can consider to do castration. Remember, in prostate cancer, castration is like the most standard treatment modality because the most common growth signal is testosterone. Then, if you want to remove that growth signal, you normally castrate the person. Then maybe that could be like some kind of prevention modalities. Huh? Yeah, otherwise there is no like natural method. Maybe if someone is, if the alcohol, if maybe unless you avoid some cancer causing agents like smoking, alcohol taking, yeah, otherwise there is no like very specific natural method is natural prevention method is about cancer. But generally it is advisable to have good lifestyle modification. That means you do regular exercise, yeah, you do regular exercise. Then after that, eat more of vegetables because they do have some antioxidant and it prevents even some anti-cancer effect. So you eat more vegetables as compared to like meat. By the way, like those who eat red meat, they are high risk of developing colorectal cancer. So like dietary, especially you can actually read about the chicken. Yeah, especially the skin part is having some carcinogenic material. Maybe you go and check about some latest information about the association between chicken meat and risk of cancer. So if someone is taking regularly meat, the risk of developing cancer, colorectal cancer is actually very high. Obesity is also risk factor for colorectal cancer because of accumulation of adipositis. So it's promoted. So generally speaking, like eating more vegetables and having healthy lifestyle is more reducing risk of cancer as compared to the other lifestyle. I think those are the information I know. Maybe if you are interested, you can actually even go and check further. How do we prevent cancer? What kind of lifestyle modification we are going to follow? Like for female, you cannot reduce like risk cancer for breast cancer, but it is advisable to do screening, like for cervical cancer and also even for breast cancer before the age of 40 and above. So those are the only modalities we can prevent. Yeah, the way there is no a single effective method to prevent cancer in the human population. That is what I know. Okay, any other question?
Sir,
Yes, please.
I have a question which is similar to Tiffany's. When a cancer when the cancer spreads, does it change in terms of its characteristics? Let's say the rate of progression, or in terms of medication, do you change the regimen, or it's just the same type of cancer but just in a different organ?
Okay. Some do, but mostly when you say a cancer normally progressed to a high level means like there is a probability the cancer undergo transformation, but it's still the same cancer, by the way, but they are more of aggressive in nature if the organs are involved. By the way, remember, distance organ involvement is like the disease is normally like is high advanced. So there is a possibility of anaplasia. That means there is a change, but still they are in the same cancer, by the way. They are the same cancer, but they are actually affecting different organ. So in terms of treatment, despite whatever we give, we can, by the way, okay, let me tell you this one first. Like most of the treatment, we are going to use it in the primary stages of the disease. They have been tested, they are effective in advanced stage. Like most of the drugs, we are going to use it in the early stage of the disease. They are effective in advanced stage. So we still use some the same treatment in terms of chemotherapy, but we are going to add some palliative measures. For example, if there is like a bone involvement, let's say if there is a bone involvement, we can still give chemotherapy, but chemotherapy alone might not be very efficient to reduce some kind of pain in the bone. You better add some kind of drugs like biphosphonate so that it reduces the bone fracture. Then maybe if there is a lung involvement, now the patient will encounter having pleural effusion, difficulty in breathing. So maybe if there is like a pleural effusion, it is good to resolve like that edema. Maybe like they can actually do chest tube to remove the edema. That is still part of the treatment. So we still use the same drug, but along with some other treatment approaches. Then apart from that, when the disease is actually more progressed or more advanced, what will happen? The performance scale of the patient might be lower. That means if you give the same chemo regimen, the patient can encounter having maybe more severe adverse effects, such as myelosuppression and etc., because of advancement of the disease. So in that condition, even sometimes we use monotherapy, sometimes even we have to like adjust the doses of the chemotherapy regimen. Yeah, so that is what we are supposed to do now when the disease is advanced. So I don't know, did I answer your question?
Yes, you did.
Okay, any other issues?
I have a question.
Yes, please.
Is there a difference between targeted therapy and chemotherapy?
Sorry.
Is there a difference between targeted therapy and chemotherapy?
Radiation therapy and chemotherapy.
Yeah, targeted therapy. I don't know if is there a difference?
Oh, okay. Okay. When you say chemotherapy is really very hard to say. There are still anti-cancer medication, but okay, I don't know how to say about the targeted therapies and chemotherapy. When you say chemotherapy, they are still part of the chemotherapy. Let's say this. When you say targeted therapies, they are still a class of anti-cancer medication. So they are just part of they are not chemotherapy. They are still chemical. I don't know what to say about this. Maybe let's just give me a minute. When you see the classification, drugs and biological agents. So you know those targeted therapies. What we say chemotherapy is antimetabolite, the poison, anthracycline, alkylating, heavy metal compounds. Those targeted therapies are biological molecule. So like the way they synthesize, they are different. So they're actually slightly different, even in terms of mechanism of action, in terms of toxicity profile. They are anti-cancer drugs, but they are not exactly chemotherapeutic agents. So from my understanding, there is a difference between chemotherapy and targeted therapies. You can actually even read how they are synthesizing monoclonal antibodies. So like they are taking the immune cell and then they, like the way it is inside, they are totally different. So chemotherapy is different from targeted therapies. So those are the chemotherapies, those are the targeted therapies. Okay, then any other question?
So could you as well say that the chemotherapy is not is also affecting the normal cells? It can also kill the normal cells. Targeted therapy is specific for the cancer cells.
Yeah, that is why targeted therapies mostly they are target specific. You know, the major problem with chemotherapeutic agents, they are cytotoxic. That means it can affect the normal cell. That is why it is actually causing the bone marrow suppression. So targeted therapies are, they are more of target oriented and they are specifically targeting the cancer cell. So that is why they are called targeted therapies. And that is why this is the latest form of treatment modalities, maybe about the bright future of cancer therapeutics. So like if you see this one, they are more target specific and the possibility of having cell destruction of the normal cell is very, very minimal as compared to the chemotherapeutic agents. Okay. Any other issues? Okay, maybe in the next 1 minute, so that we don't come back again about this issue. Remember, there are some drugs that requires dose adjustment because of organ involvement. Like if you see methotrexate and cisplatin, they can cause renal impairment. So dose adjustment is very, very important according to the creatinine clearance. So that is very important information to know. Then the carboplatin, we can use it, but there is a dosing guideline anyways. But it is an alternative, but in severe renal derangement, we also not use carboplatin. This one we shall discuss when we are discussing the treatment protocol for each type of cancer. Cyclophosphamide, bleomycin, and capecitabine, they still cause renal impairment. So dose adjustment is very important accordingly. So those are the class of drugs that require dose adjustment in case of renal impairment. Then when you see the hepatic dysfunction, like the anthracycline class of drugs, the Vinca class of alkaloids, yeah, they require dose adjustments if there is a liver dysfunction. That means if the patient is on dose regimen, we have to look at the liver function test. So we have to consider dose adjustment accordingly. Then the other point to note is like that of resistance for antimicrobial, there is also resistance for cancer chemotherapy. So I will not go in detail because that is more of pharmacology, but anyway, there is a possibility of resistance to chemotherapy. This ultimately causes treatment failure. How they can reduce delivery, then also even they reduce drug uptake. Those are some of the mechanisms. Like for example, if you see decreased uptake like methotrexate, resistance, the cancer cell normally causes a defective reduced polyclear system. So like in such a way, it reduces like resistance against methotrexate. Then sometimes even some chemotherapeutic agents causes or some cancers normally they decrease drug activation. Yeah, because some drugs are pro-drugs like the cyclophosphamide and ifosfamide, they are pro-drugs and it requires metabolic activation. So by inhibiting the enzyme that requires activation, now they can cause uh, uh, resistance. Then, if you see even carboxyl esterase is important for activation of irinotecan to active metabolite, then reduced enzyme expression may confer resistance. So some tumor can cause mutation of this enzyme and ultimately reduces activation. So those are some of the mechanisms. Some they promote efflux, some they can alter even the target protein, specifically for taxane. Remember the taxane and the vinca, they normally act on the M phase. So the tumor can alter the target site of the Z cell division, then alter resistance. Then increase DNA repair. Yes, some normally they increase DNA repair. This is very common resistance for alkylating agent. Alkylating agent causes DNA strand break, but the tumor normally increases DNA repair and continue its life cycle. Then inhibition of apoptosis, thereby reducing cell kill. Some cancer normally inhibit apoptosis in such a way they can actually promote resistance. Increased drug metabolism or detoxification. So that is also another mechanism. So those are some of the mechanisms of resistance of cancer chemotherapeutic agents. So this is all what I have for today. Maybe in the next class, we're going to discuss about some ADRs as a result of cancer chemo